Start with a case, 28 years old, male, right-handed, 2 o'clock left-sided dance weakness, medical history of cardiomyopathy, he had muscular dystrophy, left facial palsy, forced eye deviation, left-side hemiplegia, NIHS scores 20. So we just got the right-sided MCA proximal occlusion with the help of balloon guiding catheter and also aspiration catheter. There is an M1 occlusion, balloon guiding aspiration catheter, Sophia Plus. We have able to achieve a T3 recanalization without any complication. After 2 passes, under effective heparinization, next day, again had a stroke. 10 minutes symptom onset, NIH 12, again right hemispheric. So can we do a recurrent thrombectomy, consecutive thrombectomy after the initial thrombectomy? Yeah, actually we go for it, and there was an inferior division occlusion at that time, Rodnan microcatheter insertion, and after 2 passes, there was no recanalization, and then we used the combined technique with Solitaire 440 as used, and we achieved a recanalization. So can it be done? Can repeated endovascular thrombectomy can be done? Yes, there are several. There will be no randomized trial for sure, but from Mr. Clean data and also from the multi-center study, repeated mechanical thrombectomy is effective. If the patient would not have any large stroke after the first or hemorrhagic transformation after the first thrombectomy, it's available and it's feasible. So you do have a better prognosis. However, maybe associated with the unfavorable outcome regarding the when you compare it with the first thrombectomy. And let's go for the reasons under that. If you have a immediate or short-term like reocclusion, then you may need to think about several factors. One of the factors is intracranial atherosclerotic disease and residual stenosis under it. One of them will be intracranial dissection related to procedure. Residual stenosis, you need to be very careful about that. Or residual clot. There are certain things that you need to consider after the when you consider about the reocclusion. Here are some examples from the literature. If you have an intracranial atherosclerotic disease underlying your occlusion, acute occlusion, if you do only angioplasty or do nothing just to give pharmacolysis, then you need to, I agree with Sayed that you need to wait at least 30 minutes to see if there is a reocclusion or not. It's also true for tandem occlusions. If you don't want to stent the patient because of the large infarction or you gave TA, something like logic behind that, you do an angioplasty and wait. Please wait to see if there is a reocclusion or not. Sometimes it occurs, okay? And then if you miss it, it will be catastrophic. So if there is a reocclusion, then you may stent the patient after the reocclusion. And generally, I do if you have it, you can do a flat detector CT before having a decision of giving pharmacological agents like through 3B inhibitors. So if you have an underlying ICAT, in this region is quite common. Typically, in this literature from South Korea, waiting after the angioplasty or giving thyroxine to see if the artery is reoccluded again is suggested. So repeated mechanical thrombectomy is feasible. There is a incidence of recurrent stroke within 30 days between 0.7 to 5%. Mostly same territory because of the anatomical background. Even if it's cardioembolic, it goes to same territory. It doesn't mean that if you have two right or two left hemispheric strokes at the recurrent stroke doesn't mean that it's related to ICAT or carotid artery stenosis. It may happen also in the cardiomegaly case, like in this case that I presented. If it's late onset, like if you are not, if it's not an immediate or 24-hour occlusion, cardiomegaly case will be dominating because of cardiomyopathy and other reasons, or also cancer patients like paralytic endocarditis or something like that. So mechanical thrombectomy repeated cases is effective. For immediate occlusions and short-term occlusion, check for residual stenosis, check for dissection, intracranial atherosclerotic disease, residual clot also. What are the predictors of unexpected early reocclusions? Coming from the literature that was published in Stroke. The incidence of 24-hour recurrent stroke is 2.3, around about 2%. Hyperlateral, residual embolic fragments, stenosis at thrombectomy site. So these are examples. If you have a post-thrombectomy dissections, one of our colleagues asked, after successful tandem occlusion recognition, this is the case that was presented in the literature, in the supplementary. So here's the flap here. You need to wait actually. I agree with Sayed Tazar, definitely. If you don't wait, then the occlusion may occur, then you miss it. And these patients, regardless, they should be followed up in stroke unit or neurocritical care regarding to your availability, because you need to check these patients regularly, a little bit more intensively than usual patients neurologically. See, it says that the patient intracranial dissections after the procedure, because of the procedure itself, because of the stent lever, microcatheter, whatever, or aspiration catheter, and then had a occlusion, re-occlusion after that, and followed with a reasonable moderate infarction. Is another patient. They did thrombectomy. There's a residual clot in the inferior division, and then followed by re-occlusion of this clot. If you have a residual clot, you may use several pharmacological support, or again you need to wait. You need to wait. If it's in the major branch, like this in the like M3, M4 in the frontal branch or prefrontal branch, then it's questionable that you go for it. But if it's in the bifurcation branch, or if it's in the M1 branch, or if it's in the basilar branch, there's this thrombus in it. You need to be a little bit careful about it. Either you go and give some pharmacological agent, or wait, or you can go for stent lever again. So there's also, you may have a slow flow resistant flow. There's a T-occlusion of this patient with this fetal PCA. And then we recognize the patient, but see the slow flow. Still waiting, capillary phase, still waiting, and there's definitely a slow flow. Something is cooking. What? It's a tandem patient. It's a T-occlusion. Emboli, shower of microemboli that also multiple emboli can affect that as a shower of emboli.
And coronaries.
There might be also a possibility of proximal something.
Dissection.
Okay. You need to check proximally. If there is a vasospasm, if there is a dissection, if it's a tandem occlusion, there's a stent occlusion, or if there's a tandem occlusion that you don't stent, then there's an occlusion of ICH. So there's a severe vasospasm here and possibility of dissection. So if there's a slow flow, so you need to say, wait and see, look for the patient, look for the proximal, think about the possibilities, think about the vasospasm also. Sustained vasospasm can cause thrombus. Okay. If you leave the patient with a severe vasospasm, the patient might end with a thrombus overlapping the vasospasm, so you need to take care about that. If you have a tandem ICA occlusion, then you need to take care about that. So severe cardiac failure, severe hypotension can do that also. Patient cannot supply the microcirculation. So these are the things that you need to think. So carotid stenting, if you stent carotid, you need to use the proper antiplatelet medication. If not, the tendency of occlusion will be higher. So you may have up to 20% of occlusion within 24 hours with only aspirin. So you need to use antiplatelet medications or other. So if the stent is occluded, the prognosis will be worse. So you need to keep it open. So we suggest not using like heparin during the procedures. Stroke procedures the tendency of having hemorrhagic transformation is higher. So double antiplatelet treatment does not risk the increased risk of ICA generally when you stent the carotid. So these are the things that I would like to mention about reocclusions. If you have any questions, I'll be happy to answer. Thank you.
Sir, I have a question here. In our institute, what we do, as sir also mentioned, that we actually wait for about 50. Difficult to differentiate dissection versus thrombus. So what we do actually, that we go for repeat thrombectomy, and after that again we wait and see, because we want to avoid stenting the vessel. So is it recommended, or are you saying that even after first time, if it's reocclusion is there, you straight away stent the vessel?
Yeah.
So
it's sometimes very difficult to, I agree, differentiate dissection versus ICAT or residual clot.
Absolutely.
Whatever you have, actually what I suggest is if there is a flow limiting, if there is an occlusion, there is something. Okay, so its tendency to re-occlude again is higher. If there is a suspicion of calcification, if the collateral is very good, if it's a truncal occlusion, if it's a tapered occlusion suggesting that ICAT, you can directly stent. I agree with you. But if you cannot make it, is it dissection, is it residual clot, then you can give it second chance. That I agree.
That's
but if it's again reoccluded, it's most likely a dissection or ICAT, then you can stent.
Yeah, third time we do stent. Yeah. Second time we actually go for it.
There is no great evidence about this. For sure, it's a tailored approach. It can change patient to patient. Sometimes it's very difficult to make a kind of intracranial dissections. Sometimes you can miss it on the angio. What I do, if sometimes it's good to have a flat detector CT with contrast, like Dyna CT with contrast. If you open the vessel, then you give the shot, then you can maybe see a flap or dissection better in these cases. But stenting it at the end would be a strategy for bailout thrombectomy. I kind of agree. Maybe Syed will comment on that.
I agree 100%. I usually go by the first pass.
Okay, sir.
And that's where that angiogram, I did an angiogram through the Sophia with the solitaire deployed. So you see how well your solitaire expands, and you see if it's constrained, and exactly where we had crossed the lesion, the stent was crimped. So I knew that is a stenosis.
Okay.
So actually, I can give you the reference offline. The Koreans have actually written about this a lot because they do a lot of intracranial stenosis. And after their first pass, if it becomes very obvious to them, they're not going for the second or the third pass. They're committed to stenting.
Right.
Now, what influences it if you have TPA? That's where we get a little bit nervous, right? So you have TPA on board, now you're going to give Integralin or Agrostat or whatever you have available. And that's where do you have a flat panel detector CT? Do you have CT in the lab?
Yeah, we do.
Yeah, so do a CT, get a sense that there's no bleeding. But if it's intracranial stenosis that has occluded the vessel, you're likely going to need a stent.
Right.
I think in this region, like also in the United Emirates, I think it's more likely that you may have a ICAM. But in Turkey, for example, the incidence of intracranial atherosclerotic disease is very low, like 5% maybe at the most. So you start actually, if it's underlying thrombus, like residual thrombus, due to some kind of cardioembolic cause, or dissection or ICAP. It's much more difficult for us. For you, if you are in doubt, then you can stand right away.
Thank you, sir.
Is there any dedicated stents for the intracerebral vessels, or they use the same stents available?
Luminal difference between M2 and M1, so you can use coronary definitely, like Medtronic, Science, about. It depends on the tortuosity of the vessels, and it depends on the location of the stenosis. If it is in the M2, it may be difficult. But other strategy would be, there are several stents that can be used for aneurysm stents, Neuroform, Atlas, one of them. There is Akandis company, you can use the Credo stent, it's dedicated for intracranial use, or or Enterprise, another aneurysm stent. If it's a long lesion, if this is a tortuous anatomy, you can use it. There are certain strategies that you can use the balloon first, do the angioplasty, and then you can retrieve the stent in it, like case, narrow speed balloon. So there are several strategies, but you can tailor your approach according to the anatomy, location of the blood, according to the tortuosity of the vessels. But majority of patients, the coronary stents will be available, to be honest.
Great.
Thank you.
That is a very secret.
Thank you, Dr.
That's
Oscar.
a secret.